Hi everyone. So today's lecture is going to focus on Chapter 8 in your textbook, which covers prenatal procedures for genetic screening and testing. So we've talked a lot about the importance of collecting a comprehensive family history, and that doesn't change with your prenatal patients. It's important to gather a 3-generation family history, including known genetic diseases, and any carrier testing that needs to be done. Also, discussing potential risk factors based on ethnicity, and then discussion of any testing that is available for known or suspected disorders. Your prenatal history should also include menstrual history, which is timing of menses, length of menses, any pain that's associated with menstrual cycles, and then the age of onset of a menstrual cycle. Education and anticipatory guidance is a huge part of prenatal care and helping your patients to plan for a healthy pregnancy. It's important to discuss if they have pets, especially cats, because patients can be at risk for contracting toxoplasmosis. So it's important to educate pregnant patients that they should not be changing their cat's litter. If they do have a cat as a pet, somebody else needs to do that for the duration of the pregnancy. Also, the importance of avoiding hot tubs and saunas, any extremes of hot temperatures. The importance of proper nutrition. So you want to make sure that your clients have good education about the nutrition that they need. Typically, pregnant women need to consume about 500 more calories per day than a non-pregnant patient, and this is important. A lot of times pregnant women, especially with their first pregnancies, think that they're quote unquote eating for two, and so it's an excuse for them to be able to consume all the extra calories they want. But obesity in pregnancy does increase risk factors of diabetes and having a large baby. So it's important to educate them about proper nutrition during pregnancy. And then also the importance of taking a prenatal vitamin and folic acid. Folic acid is the best known prevention for neural tube defects. And so it's very important to actually start that folic acid prior to pregnancy. So if you have the opportunity to do any preconceptual counseling for patients, the importance of taking that folic acid even prior to conception. And the recommended dosage is actually 800 micrograms per day. It's also important to review immunization status and draw any titers if necessary. Most immunizations cannot be given during pregnancy, but it's a good idea to get that base knowledge in case there's any immunizations that need to be updated following the pregnancy. One exception to this is the flu vaccine, which can be given during pregnancy and actually is encouraged if your patient is pregnant during the flu season. Also, review any current and past medications. If there's any question about medications, whether or not they're safe in pregnancy, that's something that you definitely want to follow up on, and we'll talk more about that later in this PowerPoint too. Also review any history of tobacco use or alcohol, and it's important to provide education regarding smoking cessation and also cessation of alcohol use, and I'll discuss both of those later too. And then medication use during pregnancy and making sure that the medications that patients continue to stay on are safe for use in pregnancy. So in an ideal world, patients would present for preconception counseling, and you could address all of these questions and concerns during that time. Usually if patients have a good knowledge that they have a significant genetic history, they will present for preconception counseling, but the majority of patients do not. So you should identify all of this as early in pregnancy as possible. It's important to establish blood type, Rh status, and then carrier status of any possible genetic diseases. The term teratogen is used to describe an agent that potentially could interrupt the development of the fetus. There's a series of complex factors involving both mom and baby that influence the potential effect of these teratogens. There is much difficulty in establishing the safety of drugs because of the ethical constraints that come with drug testing in a population of pregnant women. One of the main things that you need to look at is benefit versus risk. And a good example of this is drugs that are used for anticonvulsants for conditions such as epilepsy during pregnancy. You need to balance the risk of these medications and the potential effects they could have on the fetus against the benefit to mom, which would be not having seizures during her pregnancy and the potential risk that those seizures could also cause to the fetus. There's many examples of this, and a lot of them are covered in your book. Page 227 to 230, table 8.4 has a not a comprehensive but a good list of medications that are known or suspected to be harmful to the fetus. But like I said, you always need to weigh benefit to mom versus risk to the baby. In 2015, there is new pregnancy categories for drugs. So drugs used to be categorized A, B, C, D, and X, with A being 100% safe during pregnancy and X being absolutely contraindicated during pregnancy. But now they have new pregnancy categories, and these categories include pregnancy, lactation, females and males of reproductive potential. So if you looked now, you would see drugs classified according to those categories and according to recommendation for use based on those categories instead of the A, B, C, D, and X. This is a copy of a table that is in your book that just shows the possible consequences of a teratogen. So they could range from no effect at all the way to postnatal function, behavioral deficits, even death of the fetus. So review that box. Also review box 8.2, which is on page 226, as well as table 8.4 and table 8.5 in your book. Those are lists of medications which potentially could be harmful to the fetus. Anti-cancer drugs is one category of medication that is becoming more prevalent because of the increased occurrence of cancer in women of childbearing age. Breast cancer, cancers of the blood. So cancer can be treated during pregnancy, but if possible, therapy should be delayed until the second trimester, and you should use the combination of medications with the least toxic effects and also the lowest dose needed. Another significant medication is Accutane, which is a medication that's used to treat acne. This is a known teratogen and often prescribed to adolescents and to women of childbearing age. Prescribers of this medication will require patients to be on some form of birth control to prevent pregnancy during the use of this medication because of the known harmful effects to the fetus. Another category is SSRIs. So we know that no medication is 100% safe during pregnancy. There are actually many SSRIs that are considered safer for use during pregnancy. But you just need to, again, weigh the benefits and the risk. We usually try to get patients to stop those medications during the third trimester because there is an increased risk of withdrawal symptoms in the infant, and also a condition that's called persistent pulmonary hypertension that is often seen in the newborn. So not that SSRIs are not prescribed during pregnancy, but they're definitely prescribed very cautiously. And again, just like the chemotherapy agents and any other medication that you would use in pregnancy, you need to make sure that you are weighing the benefits and the risk, using the absolute lowest dose possible to receive or to achieve efficacy. Sorry, I'm stumbling over my words here. And definitely follow these patients very closely. And you also need to educate your patients. They need to understand the potential risks that are associated with these medications. Even Tylenol is not 100% safe during pregnancy. The only 100% safe during pregnancy is to not use any type of medication, and that's not always an option for most patients. So, what are our nursing responsibilities when it comes to prenatal care, preconception counseling, and genetics? So, we need to be educating all women. We need to be educating women before they get pregnant, during the course of their pregnancy, and even after pregnancy, because you never know who our patients are going to come in contact with, and maybe even our older generation of parents can take that education, or patients can take that education back to their daughters that may be of childbearing age. It's important to identify all current and past medication use so that we can identify any medication that could potentially be harmful to the fetus. Involve your client in decision making. So make sure they know these are the risks that are associated with use of these medications. These are the risks that are associated with smoking in pregnancy, and provide them with the education that they need to make informed decision. If you do need to use a medication in pregnancy, use the lowest dose possible. And then again, always looking at risk to mom or risk to baby versus benefit to mom. We all know that the use of alcohol in pregnancy is not advised. Interestingly enough, it wasn't until 1980 that the Surgeon General actually came out with a statement advising pregnant women that they should not drink alcohol during pregnancy. Alcohol actually used to be treated or used to treat preterm labor in pregnancy, so it was given through IV in an IV drip, just kind of a little tidbit of history there. But now we know that alcohol causes severe effects to fetuses during pregnancy. There's a condition called fetal alcohol syndrome, and it's actually a spectrum of disorders listed here. It's kind of an umbrella term for alcohol-related conditions. So nurses should be aware of referral information for women who are of childbearing age, either during preconception counseling or during those early pregnancy visits, for women seeking help with alcohol addiction or alcohol consumption. It's also important as nurses to know the symptoms of alcoholism so that we can identify those women that need our help. Encourage cessation of alcohol use prior to pregnancy. So if you have the opportunity to do prenatal counseling with your clients, encourage that alcohol use be stopped actually prior to pregnancy. And then it's also important to provide postpartum follow-up, especially if these women are breastfeeding and they are able to stop alcohol use during pregnancy or go through some sort of counseling for their alcohol addiction during pregnancy. It's important to provide them with the postpartum follow-up and continue that counseling and that treatment if needed. Cocaine and the use of other street drugs during pregnancy can have multiple effects on the fetus, including intrauterine growth restriction, low birth weight, increased incidence of fetal loss, preterm birth, obstetrical complications, microcephaly, which is lagging growth of the fetal head, multiple congenital malformations, neurologic and behavioral effects as well. One of the more common risks that you will identify during preconceptual counseling or pregnancy counseling is the incidence of cigarette smoking. So maternal cigarette smoking is very dangerous to a baby, and it's important to provide education to our parents regarding the risks associated with the use of tobacco. It's not only dangerous when, obviously it's dangerous when you're not pregnant, but if you think about your pregnant patients, you're actually taking care of two patients. You have a mom and a baby, and those cigarettes have an impact on the baby too. There's an increased rate of miscarriage, increased rate of sudden infant death syndrome, increased rate of complications to mom, both during the pregnancy and during labor. You guys will learn about placental abruption and placenta previa in maternal child class, and we'll also talk about those a little bit in OB clinical, but there's an increased incidence of complications with the placenta, increased incidence of low birth weight, and that is obviously related to perfusion through the placenta, increased incidence of preterm delivery, and a higher rate of low APGAR scores at birth. So another one that we don't really see a lot anymore is exposure to radiation during pregnancy. There's enough knowledge about it now and a lot of questions. Think about going to the dentist's office or nurses, providers, patients in radiology. So they're always asking about the potential of pregnancy and shielding the abdomen when needed. But it's very important to identify possible exposure to radiation in patients that have the potential to be pregnant or are pregnant. Table 8.6 in your book reviews a list of maternal infections that are associated with poor fetal outcomes. There is a very long list, including cytomegalovirus, varicella, parvovirus, rubella. I could go on and on, but basically, fetal consequences associated with most of these infections include fetal death, preterm delivery, or of both a normal infant or also preterm delivery of an infant with growth restriction. So what prenatal testing is available to our patients? So we need to differentiate between prenatal testing for detection of fetal anomalies and diagnosis of fetal anomalies. So for detection, there is serum screening and also ultrasound, and then the actual diagnosis comes from ultrasound, amniocentesis, either fetal blood or tissue sampling. And then probably the newest and most interesting, exciting, whatever you want to call it, is the information that's coming from fetal cells and fetal DNA, which are found in the maternal circulation. So an example of this is the integrated screen or the early first trimester screening that can be done in our pregnant patients. So this is a combination of two things. It's a first trimester ultrasound, so an ultrasound done in the first 12 weeks of pregnancy, and that's combined with two blood draws, a blood draw that's done on the same day as the ultrasound, and then a blood draw that's done sometime between 16 and 20 weeks of gestation, and they take the results of all of these three tests and put them together, and mom can get a kind of like a screening diagnosis. So what her risk level is based on her age and her gestation and any familial factors that we factor in, and then looking at the results of the blood work and the ultrasound. So this is kind of the newest up and coming way that we are able to do fetal screening. And the thing that I think is really awesome about this is it used to just be if you had an abnormal screening, the only way to get diagnosis was to do amniocentesis, which is not 100% safe for baby. It comes with an increased risk of miscarriage because you're inserting a needle into the amniotic sac. There's risk of rupturing the membranes, risk of harm to baby. And so being able to obtain this information from maternal blood is pretty amazing for patients, and the accuracy of it is like 99%. So looking at that compared to something like an amniocentesis or chorionic villi sampling is a huge advantage to women. So who do we test? We've talked a lot about the importance of identifying individuals who are at risk. Table 8.9 in your book provides you with a list just as kind of a reminder of the patients that are at risk. Also, remember the importance of taking history in your patients in order to identify those at risk, and also keeping that history updated. That's very important every time that a patient comes into your office or hospital, whatever setting you're in, that you're getting your patient history, to keep updating that history, always asking if there's any new diagnosis of the patient, any new diagnosis of the family that needs to be added to family history. So the last thing that I want you guys to do for today is to do this case study in Evolve. So it's in your HESI patient reviews. If you go under the maternity tab and problems of pregnancy, the patient is Donna Pro. It's a case study of caring for a woman who uses cocaine during her pregnancy. So I picked this one just because this is something that you probably won't run across in clinicals. I can actually only think of one or two patients that I've actually come in contact with, thankfully. But just kind of an interesting turn of things, probably something that you guys won't normally see, and something that we did touch a little bit on during this lecture. So just go through that case study and try to get that done before the end of the week. There's no deadline set on it, but I do want you guys to all do it, and I'll be checking Evolve for your scores and making sure that everybody has it done. So please email me if you have any questions over the course of the next week and a half as you're going through and doing your pedigrees. I will see you guys in lab both this Friday and next Friday, so you can always ask me questions in lab too, or after lab. A lot of times I'm in my office after lab too. But otherwise, I hope you have a good week and a half, and I will see you guys, like I said, in lab, and then I'll see you back in class in a couple weeks.